Hello everyone, welcome to the Image Advantage series brought to you by STEP by Global Healthcare Academy. I am Dr. Kamal Jain and I am your faculty for Orthopedics, and today we are going to go over a few image based questions and concepts which are important for you from your NEET PG perspective. So without any delay, let's dive straight into the questions. The first one, a child presents with an injury to his knee while playing. Radiographs show a fracture of the femur as shown below. So as you can see, I have not put any questions or any options. This is because I want you to understand the concept, the topic, so that you are able to answer any questions that come from this area. Okay. So in the question, we have clues like a child and a fracture of the femur. We can see in the radiograph, this is a radiograph of the knee which shows the femur and the tibia. The tibia looks normal. This is the epiphysis. This is the metaphysis, and in between is the physis. So the tibia looks normal, whereas in the distal femur you can see that the epiphysis looks normal. However, there is a fracture in the metaphyseal area and there is a triangular piece of fragment of the metaphysis. Okay, so any child presents to you with a fracture around the physis, the first thing that should come to your mind is the Salter-Harris classification. Salter-Harris is basically the classification of physeal injuries in children. It is divided into 5 basic types at your level. Type 1, 2, 3, 4 and 5. The mnemonic to remember this is Salter, S for type 1, A for type 2, L for type 3, TE for type 4 and R for type 5. So this basically describes the orientation of the fracture line. So type 1 is straight through, which means that the fracture line passes straight through the physis. As we know, the physis is a cartilaginous structure and cannot be seen on the X-ray. However, the relation of the metaphysis and the epiphysis will be altered in such injuries. For example, in this X-ray of the distal tibia, we can see that the metaphysis looks normal. The epiphysis also looks normal. However, the orientation of the epiphysis with respect to the metaphysis is altered. So this is an example of a type 1 Salter-Harris injury. Another important example, which is an important exam question also for you, is slipped capitofemoral epiphysis. So in slipped capitofemoral epiphysis, basically you have the femoral epiphysis and the femoral metaphysis. Okay, so this epiphysis slips over the metaphysis, and SCFE is basically an example of a type 1 Salter-Harris injury. The second type stands for A, above. So the fracture line starts at the physis and exits above into the metaphysis. Above into the metaphysis. So this is an X-ray. Here you can see of the distal tibia. This is the metaphyseal region. The fracture line starts here and exits above into the metaphysis, leaving a triangular piece of bone. This triangular piece of bone is known as the Thurston-Holland fragment. This is also an exam based question for you. Okay, the triangular piece of bone is known as the Thurston-Holland fragment. One more thing you need to remember about type 2 injuries is that they are the most common type of Salter-Harris injuries, and they account for 75% of all the Salter-Harris fractures. Type 3 is where the fracture line starts at the physis and exits lower into the epiphysis. Okay, so here you can see the fracture line starts at the physeal plate and is exiting into the epiphyseal region. So the epiphysis, you know, is part of the articular side of the bone. Okay, so any epiphyseal injury will directly make it a intra-articular fracture, and any intra-articular fracture, the thing you need to remember is that they always require surgical intervention, whether it be open reduction or closed reduction, it always requires a surgery. The fourth type is through everything. The fracture line starts at the epiphysis, passes across the physeal plate and exits above into the metaphysis. For example, here in the distal tibia, you can see that the fracture line has started here in the epiphysis, passes through the physeal plate and exits above into the metaphysis, leaving a small triangular piece of bone, which is again the Thurston-Holland fragment. Okay, and this is an example of a type 4 Salter-Harris injury. You can see here in the fibula, the epiphysis looks intact, the metaphysis also looks intact. However, the relation between these two is definitely altered. So, the fibula here is an example of a type 1 Salter-Harris injury. Type 5 R stands for rammed or crushed. So, basically what happens here is because of a compressive force, the physis is the weakest area of the bone, and hence any compressive force, the physis undergoes complete crushing. Okay. So, as we have discussed, the physis is a cartilaginous structure, and sometimes because of this you cannot see the fracture and the x-rays can be normal. However, if the crushing force is continued, you can have crushing of the epiphysis as well, which is an indirect marker of the physeal injury. For example, in this case you can see that the radial head epiphysis is comminuted or crushed. So, this is an example of a type 5 Salter-Harris injury. So, this is the Salter-Harris classification. Now, let us dive a little deeper into the structure of the physis. So, this is an image of the physis, a diagrammatic representation. This is the epiphysis, this entire region is the physis, and this is the metaphysis. So, the epiphysis is divided, the physis is divided into further zones. First zone is the reserve zone, which basically consists of the germinal cells. It stores all the materials that are necessary for proliferation, like lipids, glycoproteins, sphingolipids, etc. Okay. So, once the reserve zone gets a signal, it starts undergoing rapid proliferation and forms the proliferative zone. Here the cells rapidly increase in number and form longitudinal columns. After proliferation, the cells undergo enlargement in size to form the hypertrophic zone. This zone is important for you to remember. We will discuss in a few moments as to why. Okay. So, once proliferated, the cells start maturing first. As you mature, then you eventually have to grow old as well. So, it undergoes degeneration. After degeneration, there is the zone of provisional calcification. Here is basically where the mineralization of cells occurs. Calcium starts depositing to form the bone. So, after zone of provisional calcification, there is maturation of collagen as well to form the primary spongiosa. We have the maturation of collagen in this zone. And then the primary spongiosa further matures to form the secondary spongiosa of the metaphysis. So, this is the structure of the physis. If you see on a histopathological slide, again here where the cells are sparsely distributed is the zone of reserve cartilage. Then they start forming longitudinal columns, which is the zone of proliferation. Then they start to enlarge in size, which is the zone of hypertrophy. And here the vessels start invading into the zone of provisional calcification, and this entire zone is the zone of provisional calcification. Okay. So, now let us look at the different diseases that are associated with different zones of the physis. So, in the reserve zone, as we discussed, it is storing materials that are necessary for proliferation. So, any disorders that affect these materials can affect the reserve zone. For example, in Gaucher's disease, which is basically a deficiency of beta glucocerebrosidase, there is accumulation of sphingolipids in this area, and this affects the reserve zone. So, reserve zone Gaucher's disease will affect the reserve zone. In proliferative zone, if there is hyperactivity, then it will result in gigantism. Basically, the activity of the proliferative zone will decide the final length of the bone and the final height of the person. So, hyperactivity will lead to gigantism and underactivity will obviously lead to dwarfism. Okay. So, in the hypertrophic zone, what you have to remember here and why you need to know that this is the important zone is, first, all the physeal injuries occur in the hypertrophic zone. So, physeal injuries basically pass through the zone of provisional calcification. Okay. And the second important thing that happens here is, as we know, in the zone of provisional calcification we have mineralization that occurs. So, any disorder of mineralization can affect this zone of provisional calcification, and the important one that we remember and we know is vitamin D deficiency or rickets. So, the rickets will also affect the zone of provisional calcification. In the primary spongiosa, we have a maturation of collagen. Alright. So, any disorder that results in defective collagen maturation will affect this zone, and as we remember and as we know, vitamin C deficiency or scurvy affects collagen metabolism, and hence scurvy will affect the region of primary spongiosa. So, these are the different diseases that are associated with different regions of the physis. So, let us go over a few questions that have been asked previously. Which of the following is the most common complication of physeal injuries? So, physeal injuries, as we know, it is the growing area of the bone. So, basically growth arrest should be your most likely option here. Non-union osteomyelitis, in non-union in children, is a pretty rare complication. Osteomyelitis can occur, however, it is not particularly relevant to physeal injuries and can occur in any fractures in children. Avascular necrosis definitely can occur in a physeal injury, especially as we know in type 1 slipped capitofemoral epiphysis, there is a risk for avascular necrosis of the femoral epiphysis. However, when we consider physeal injuries overall, the most common complication here will be growth arrest. Okay. The next question, which Salter-Harris type of physeal injury is the most common in children? This we have already discussed. Type 2 is the right answer here. It accounts for 75% of all Salter-Harris fractures. Type 1 accounts for around 10%, type 3 accounts for around 10%, type 4 accounts for about 5%, and type 5 accounts for less than 1% of all Salter-Harris injuries. A 12-year-old presents with a distal tibial physeal injury after a fall. Radiographs show a Salter-Harris type 3 fracture. What is the most appropriate management? So, in our mind, let us create the distal tibial region. This is the metaphysis, epiphysis, and it has been written that it is a type 3 injury. So, SAL, which is lower. So, the fracture line basically starts along the physeal plate and exits lower into the epiphysis. So, as we have discussed, this is basically an example of an intra-articular fracture, and any intra-articular fracture requires surgical intervention. So, surgical intervention will be a right option here, and in our options we can see that option B is the most appropriate or relevant option here. So, the fixation modality or fixation modality of choice will be fixing it with a screw, passing a screw across the epiphysis to fix the fracture. Which of the following mechanisms is most likely to cause a Salter-Harris type 1 injury? Okay, so let us just draw the physeal region first. This is the metaphysis, this is the epiphysis, and this is the physeal plate. So, let us go through the options. Shear force. So, shear force basically means a transverse force applied across the epiphysis. So, whenever a force like this is applied, as we all know, the physis is the weakest region. So, when you keep continuously applying a pressure across the epiphysis, eventually a fracture line will occur across the physis and the epiphysis will separate from the metaphysis, which as we know will result in a type 1 Salter-Harris injury. So, shear force is the right option here. Compressive force, as we have discussed, when a compression is continuously applied across the epiphysis, first thing to get compressed and crushed will be the physis, followed by the epiphysis. So, usually this will result in a type 5 injury. So, compression force will result in type 5. Rotation and tensile forces, usually depending upon the position of the extremity during the time of injury, it can result in any of these type 2, 3 or 4 Salter-Harris injuries. Okay. Now, let us go over another important concept, the radiological features in vitamin C and vitamin D deficiency. So, vitamin C deficiency, which is also known as scurvy. Let us go through the important radiological findings in scurvy. So, vitamin C deficiency, there is definitely tendency for bleeding. So, the periosteal capillaries usually undergo spontaneous rupture and bleeding to result in subperiosteal hemorrhages. Then we have a dense zone of provisional calcification or the white line of Frenkel. So, this occurs because vitamin D is normal in such cases. So, mineralization will continue. However, its maturation into primary spongiosa is delayed because of vitamin C deficiency. So, this results in excessive calcification, which results in this dense zone of provisional calcification. And as we have discussed, just above the dense zone of provisional calcification or the primary spongiosa, the collagen maturation is defective. This defective collagen maturation results in weak bone and minor fractures as well as small hemorrhages. So, all these three combined will result in a translucent zone right above the dense zone of provisional calcification. This is known as the scorbutic zone and this is pathognomonic of scurvy. Then we also have the ring epiphysis, which is basically a dense sclerotic ring around the epiphysis. The Pelton spur is nothing but the dense zone of provisional calcification, which is extending to the periphery to involve the periosteum as well. So, these are the mechanisms for the different radiological findings you see in scurvy. Next thing we will go through is the radiological findings in vitamin D deficiency or rickets. So, rickets basically, as we have discussed, it affects the zone of provisional calcification. So, zone of provisional calcification, there is not adequate mineralization in this area and hence the edges are not well defined, and this ill defined edges is known as fraying. Now, since the calcification does not occur properly in this area, this bone is soft while the epiphysis is normally growing and hence this bone is hard. So, anytime you push a soft structure against a hard structure, definitely the soft structure will tend to undergo something called as splaying. So, the region widens and this is known as splaying. This happens only if the child is walking on the extremity or weight bearing on the extremity. As you continue weight bearing on this extremity, this soft bone will remodel around the epiphysis and cup it. So, the epiphysis stays in its place normally while the soft metaphysis tends to remodel around it. This results in something called as cupping. So, these are the different mechanisms by which you see the findings that you normally see in rickets. So, this brings us to the end of the first concept where we have learnt about physeal injuries. We have learnt about the Salter-Harris classification. In brief, we have also learnt about the management. Then we have learnt about the structure of the physis and the diseases that were associated with it, and the last thing that we have learned are the radiological features of scurvy and rickets. Not just the features, we have also learned the mechanism by which it occurs, which will ensure that you don't forget these findings. Going on to the next concept, a 13-year-old obese boy presents with left hip pain and a limp. An X-ray of the pelvis with both hips is performed. What is the most likely diagnosis? So whenever in a question you get a obese adolescent male with a hip pain, the first thing that you should think about is slipped capitofemoral epiphysis. Okay, so as you can see in the options, we have slipped capitofemoral epiphysis in option B, which will be the right option. However, let's confirm our diagnosis by looking at the X-ray. So this is an X-ray of the left hip. This is the acetabulum. This is the femoral epiphysis, and this is the femoral metaphysis. So as we can see, the relation of the epiphysis and the metaphysis is definitely disturbed. The epiphysis has slipped over the metaphysis. So this is an example of type 1 Salter-Harris injury, as we have already discussed, and this is slipped capitofemoral epiphysis. Perthes disease, this relation is usually maintained. However, the epiphysis undergoes avascular necrosis and it becomes smaller in height, and it can also become fragmented. So Perthes disease is not the right option. Developmental dysplasia of hip usually presents with a painless limp, and also the relation of the acetabulum and the epiphysis will be altered and not the epiphysis and the metaphysis. Septic arthritis, usually they will give you a few other clues like presence of a fever or increased counts or increased ESR, CRP. So this is also not the right option. So the diagnosis is slipped capitofemoral epiphysis. Now this is a radiograph of the pelvis with both hips of a patient with slipped capitofemoral epiphysis. The right side is the normal side. As we can see here, this is the femoral epiphysis and this is the metaphysis. So if we draw an axis along the superior part of the neck of femur, it usually passes across the femoral epiphysis as well. This line is known as Klean's line. On the left side, which is the pathological side, this is the femoral epiphysis, this is the femoral metaphysis. And here if I draw the Klean's line, definitely it is nowhere near the femoral epiphysis. So this sign where the Klean's line does not pass through the femoral epiphysis is known as Trithoven's sign. Okay. So this was the anteroposterior radiograph. Now let's look at the frog leg lateral. So this is a frog leg lateral radiograph of the hips. Again, the right side is the normal side. You can see the femoral epiphysis and the femoral metaphysis. Here if I draw a line along the axis of the neck, it usually passes or is along the axis of the femoral epiphysis as well. On the left side, if I draw a line along the axis of the epiphysis and the axis of the neck, they make an angle to each other. This angle is known as the Southwick's angle, and this angle determines the severity of slipped capitofemoral epiphysis. So if the angle is less than 30 degrees, it is a mild slipped capitofemoral epiphysis, and the management for this is usually in situ pinning, okay, where you just directly pass screws across the metaphysis and the epiphysis. 30 to 60 degree is moderate, and more than 60 degrees is a severe degree of slip. In these two cases, usually if it is an acute injury, close reduction plus pinning is the modality of treatment. If it's a chronic case, usually an osteotomy is also required. So the risk factors for slipped capitofemoral epiphysis, please remember this image as well as the mnemonic fat teen. So it's usually a fat or an obese child, obese adolescent or a teen, roughly between the age of 10 to 16 years. They usually have some form of thyroid dysfunction. As we have discussed, hypothyroidism will lead to obesity, and hence usually it's hypothyroidism that is more common. They can have other endocrine disorders like growth hormone deficiency. Such children also have a history of early onset or delayed puberty. Okay, they can also have other neuromuscular disorders like Down syndrome. Okay, so these are the risk factors for slipped capitofemoral epiphysis. One thing you also need to remember is any obese adolescent with knee pain but a normal knee X-ray, you also have to think of slipped capitofemoral epiphysis. This is usually because of referred pain. Alright. So the next thing will be to remember the clinical features of slipped capitofemoral epiphysis. The mnemonic is SCFE, slip. Again, if the onset is slow, it is usually a chronic case. However, it can have a rapid onset or acute onset in case of trauma. So it's usually a child, as we have discussed. Alright, they present to us with an external rotation deformity, and this will definitely result in limited internal rotation as well. So clinical features will be external rotation deformity and limited internal rotation. Next thing we'll do is radiological investigation, which will be a slipped epiphysis on the AP view, and frog leg laterals are taken for determining the severity. In situ pinning is the modality of treatment in mild cases. The last thing that you need to remember is pain can be referred in the knee. So this also you have to remember. Okay, so this was about slipped capitofemoral epiphysis. We have learnt about the clinical features, the radiological features, as well as the risk factors. And in brief, we have also learnt about the management of slipped capitofemoral epiphysis. Okay, so let's go through the next question. A 15-year-old boy presents with a chronic discharging sinus over the femur. Radiographs were done. What is the most likely diagnosis? So the moment you see a chronic discharging sinus in your question, the first diagnosis that should come to your mind is chronic osteomyelitis. So chronic discharging sinus is the clinical hallmark of chronic osteomyelitis. Okay, let's still go through the other options. Ewing sarcoma, it can mimic acute osteomyelitis. However, Ewing sarcoma and osteosarcoma, both of them will usually present with a swelling without any discharging sinus. So hence these two are out of the question. Tubercular osteomyelitis is a possibility. However, it usually or commonly affects the vertebral body, and hence the most likely diagnosis here is chronic osteomyelitis. If you go through the radiograph, we can see that there is a dense sclerotic bone in the medullary canal. This is the sequestrum. Surrounding the sequestrum, we have a radiolucent zone, which is the granulation tissue. Okay, and then we have this sclerotic reactive bone margins around it. Okay, so the diagnosis is chronic osteomyelitis. Let's go through the pathophysiology of chronic osteomyelitis. So it starts off always with acute osteomyelitis, which usually affects the metaphyseal region of the bone. This metaphyseal region is affected because of two things. The first hypothesis by Trueta is that there are hairpin loops of vessels in the metaphyseal region. These hairpin loops make the blood vessel or the blood flow sluggish, which helps the bacteria escape from the blood flow and enter into the metaphyseal region. So that is one. The second theory by Hobo is that the metaphysis has decreased immunity due to decreased leukocytes in this region. So these two factors contribute to the development of acute osteomyelitis in the metaphyseal region. So this is the formation of the abscess, which is the hallmark of acute osteomyelitis. So as acute osteomyelitis progresses, the pus inside continues to develop, and eventually this pus will travel through the Haversian canals and reach the subperiosteal space, and it will elevate the periosteum. Okay. So as soon as the periosteum is elevated, we know that the blood supply to the bone comes from the periosteal blood vessels also. So this blood supply is cut off. This results in this bone undergoing necrosis, which results in the formation of dead bone inside, which is this sequestrum. Okay. So our body also responds by forming a bone around this raised periosteum, and this new bone formation is known as the involucrum. So sometimes the body is successful in walling off the abscess, alright. However, this sequestrum inside serves as a nidus for infection. So the pus inside continues to build, the pressure inside continues to build, and clinically the patient will have increased pain and increased swelling. This continues until eventually this pressure results in the abscess to come out through the involucrum to form a discharging sinus. Okay. So this discharging sinus will have pus as well as the sequestrum coming out from it. Okay. So eventually once the discharging sinus comes, the patient's pain and swelling will both come down. As the pressure inside decreases, the body can again wall off this abscess, and this cycle can repeat. So this cycle of repeated pain and swelling increasing followed by sudden decrease with the appearance of a discharging sinus is known as the Wallenkamp phenomenon. Okay. So this is the pathophysiology of chronic osteomyelitis. So let's go over a few important most commonly asked questions in chronic osteomyelitis. So the first thing is the most common route of spread. Most common route of spread is hematogenous. The most common organism. So the most common organism that is implicated in osteomyelitis is Staphylococcus aureus. And this holds true no matter what the condition of the patient is, even in AIDS, diabetic patients, or any immunocompromised states. The most commonly implicated organism is Staphylococcus aureus. There are a few exclusions. For example, in IV drug abusers, the organism that is commonly implicated is Pseudomonas. Then in sickle cell patients, sickle cell anemia, In such patients, usually it is Salmonella. However, this is true only if the diaphysis is involved. If you have a sickle cell patient having osteomyelitis in the metaphysis, the organism implicated is still Staphylococcus aureus. And in human bites, it is usually Echinella, and in animal bites, the organism that is implicated is Pasturella. Then the next thing is the most common site of infection. So, the femur is the most common site of infection. Again, in the femur, it is usually the distal femur followed by the proximal femur, which is more common, and after femur it is the proximal tibia. So, this is the case of children as well as the overall rate of osteomyelitis. However, if you are considering only adults, then the vertebral body is the most common site of osteomyelitis in adults. Okay. The next thing will be your investigations. So, the investigation of choice will be MRI in the first 24 hours. X-ray wise, you can see soft tissue changes usually within 24 to 48 hours, and bony changes are first seen only after 7 to 10 days of the infection. Then you also have scintigraphy. So, amongst the scintigraphies, indium 111 is the most specific. You have other modalities as well, like gallium 67 scans and technetium 99 methylene diphosphonate. However, out of these three, indium 111 is the most specific. The gold standard for diagnosis of osteomyelitis is biopsy, where you aspirate and do a culture sensitivity of the pus. This is the gold standard for osteomyelitis diagnosis. Management wise, acute osteomyelitis, usually it is antibiotics plus or minus incision and drainage. And chronic osteomyelitis, antibiotics definitely are given for at least 6 weeks. However, along with it, you also have to do a surgical intervention with sequestrectomy, because as we have discussed, the sequestrum is a nidus for infection, and unless that is removed, the infection will continue to propagate. So, a sequestrectomy with saucerization and debridement. So, while debriding, to differentiate between healthy and the unhealthy bone, we have something called as the paprika sign, which is the pinpoint bleeding, signifying good healthy bone. Alright, so this is the next concept. The next question here, a 25-year-old man is brought to the ER after a head-on car collision where his knee struck to the dashboard. So, basically this is an example of a dashboard injury. A dashboard injury to the knee, the first thing that should come to your mind is a posterior dislocation. So, basically it is a guy who is sitting like this is the dashboard, and there is a head-on collision. So, the knee hits the dashboard and this force is propagated upwards at the hip, and the hip dislocates out posteriorly. So, we will confirm our diagnosis with the image. So, in the image you can see that the hip is in flexion, the hip is adducted, and the hip is internally rotated, where you can see that the medial edge of the foot is touching the bed. So, this is a FADIR or a Fadir deformity, okay, and you can also see that there is some shortening as well. So, a Fadir deformity with shortening your diagnosis is confirmed to be a posterior hip dislocation. Anterior hip dislocation usually presents with a flexion, abduction and external rotation deformity with lengthening. Okay. Femoral neck fracture and acetabular fractures, again they will present with a flexion, abduction, external rotation, flexion, adduction, external rotation deformity. However, they will have shortening. So, the correct answer here is a posterior hip dislocation. Now, let us compare the two different types of dislocations. So, the anterior and the posterior dislocations are the common ones. In anterior dislocation, as we have discussed, the deformity is flexion, abduction and external rotation. Whereas, in posterior dislocation, we have flexion, adduction and internal rotation. And there is definitely shortening in cases of posterior dislocation, whereas you will have lengthening in cases of anterior dislocation. Usually when the femoral head dislocates anteriorly, the femoral head will be palpable in the femoral triangle, whereas in posterior dislocation the femoral head will be palpable in the gluteal region. And the most commonly injured structure, if you particularly consider only anterior dislocation, will be femoral vessels, whereas in cases of posterior dislocation it will be the sciatic nerve. However, if you consider the overall complication rate, then in any hip dislocation, avascular necrosis is the most common complication. Okay. So, that brings us to the end of today's session. Today we have learnt about the different types of physeal injuries. We have learnt about radiological features of rickets and scurvy. We have learnt about the structure of the physis and the diseases that are associated with it. We have learnt about slipped capitofemoral epiphysis. We have learnt about chronic osteomyelitis, and we have also learnt about hip dislocation. All important topics from your NEET PG exam point of view. Hope you have understood the concepts that I have tried to discuss here today. If you have any doubts, please feel free to reach out to us. And with that, today we will conclude the session on the image based advantage, brought to you by STEP by Global Healthcare Academy. Thank you.